Hello everybody. Today we're going to be talking about mood disorders, which consist of anxiety and depression. And we'll start with depression. Oh, let me get this slideshow the way we want it. Depression is the most prevalent of the mood disorders, and even though we talk about the word depression in kind of our everyday language, saying I feel depressed, meaning I feel sad, there are actual criteria for a diagnosis, a clinical diagnosis of depression. And so depression for the diagnosis is characterized by an unhappy mood, but also by other things like loss of interest, reduced energy, changes in appetite and sleep. People are not hungry and not sleeping very much, or they can have the opposite pattern where they're eating a lot and they're sleeping a lot. Difficulty in concentrating, being potentially restlessness, pessimism, and thoughts of death, hopelessness, helplessness, feeling as though things will never get better. And depression may last for several months. We typically think of depression as cyclical, meaning once someone has the diagnosis of depression, it doesn't typically last their entire life, but there will be periods of depression that could be weeks or months, perhaps even years, and then feelings of kind of a more normal, typical emotion, and then again, a period of depression. So sadness, helplessness, again, for days, weeks at a time, low energy, feeling worthless, maybe suicidal, and getting little pleasure from things that would typically make people happy. If I said, we're going to Disneyland, that wouldn't make someone happy. Really good food, really good sex, none of those things give people the pleasure that typically they would get. We see depression in 2 times as many women as men, and it affects about 5% of adults at any one time. So it's a pretty prevalent mental disorder. Depression can occur at any age, but it's more common to occur between adolescence and old age, meaning it's rarer to see depression in children, excuse me, but it can happen. I worked at an inpatient psychiatric hospital for children, and we have children who were diagnosed with depression, young children, so 7, 8, 9 years old, but that's much more rare. The risk for depression is greater if relatives have depression before age 30, so earlier onset. And we see this with a lot of the mental disorders, that the earlier the onset, the more biologically based they appear to be, the more they run in families, the more genetics seem to be involved. The symptoms of depression are similar to symptoms of different hormonal problems, head injuries, brain tumors, and other illnesses, which is why it's really important to get a very good diagnosis and a very thorough history of what is happening with the person to rule out any of these other issues before someone is diagnosed with depression, because you would obviously treat these sorts of issues differently, right? A head injury or a brain tumor, as opposed to depression or something like Parkinson's disease. And like I said, is often excuse me, comorbid with other disorders. Comorbid meaning occurring together. And so you can see depression with a person who's diagnosed with schizophrenia or diagnosed with a substance abuse disorder or an anxiety disorder or Parkinson's. And we actually do see this quite a bit when we're talking about different psychological disorders, that it's it's not uncommon to see someone with multiple diagnoses or multiple comorbidities. So someone diagnosed with depression and substance use disorder and an anxiety disorder. That is not uncommon at all. Inheritance is part of the determinant in depression. We see studies of twins and adopted children that suggest a moderate degree of heritability. So if one twin is diagnosed with depression, there's an increased likelihood the other twin will also be diagnosed with depression. And when we talk about adopted children, we see that if children are adopted into a different family, if their biological family, people in the biological family have depression, then it's more likely the adopted child, the one who's adopted away from that family, will also have depression, suggesting that genes or biology plays a role. In terms of brain changes that we see in depression, there's increased activation in the frontal lobe during cognitive tasks and the amygdala, which is part of our emotional processing. We see decreased blood flow to areas of the brain implicated in attention, and the cortex in the right hemisphere seems to be thinner. Depression in the brain. We know that hormonal changes can trigger episodes of depression in some women. And so there seems to be an interaction of heredity or genes and the environment that and can often be triggered by traumatic events as well. And we see also this pattern in many of the psychological disorders that we'll talk about, that it's not purely genes or it's not purely environment, but it's a combination of the two. That somebody has genes that maybe predispose them to potentially having symptoms of depression, but something happens in the environment, whether it be some traumatic event or they lose their job or something happens that sort of triggers these symptoms. Stress can elevate cortisol. Cortisol is our stress hormone, and that can lead to decreased energy, impaired sleep, decreased immune system, and that kind of whole grouping of um, effects from this elevated cortisol level can then lead to depression. So we can see depression kind of going in that pathway as well. There are many pathways to someone ending up with symptoms of depression. Like I said, you can have depression in childhood. In childhood, depression is equally common in girls and boys, but after puberty, we see depression twice as common in females, and this finding is consistent across cultures, suggesting some kind of biological factor, that it's not maybe an environmental factor necessarily, but that there's some biology to this. In terms of treatments for depression, well, these are two of the maybe least used. These are some newer, well, I wouldn't say newer. ECT is an older therapy, but not as used. Electroconvulsive shock therapy is when they pass a strong electrical current through the brain that basically causes a seizure and in some way leads to depression reduction. You may have seen something like this in a movie and it looks awfully terrifying, and perhaps when they first started ECT, it wasn't a very particularly humane procedure. However, it is done rarely in hospitals. It's done here in San Diego. I've even seen it done in a hospital setting, and they do it in a very, again, uh, just like any medical procedure, the person is anesthetized. There are electrodes that are placed on their brain, they're monitored, and they're looking to put enough electricity through those electrodes in the brain to induce a seizure. And as soon as they see seizure activity on the EEG, the brainwave monitors, they stop putting any more electricity through those electrodes. And in fact, it works. And that's one of the amazing things. Why does it work? Nobody knows for sure, but people who have very long-term, intractable depression. They've tried every medication, they've tried every therapy, and nothing works. So you have someone who is hopeless and probably imminently suicidal. They're in a psychiatric hospital and there's really nothing that can be done. They've tried everything. Then this may be a treatment of last resort. And so I just want to check. I thought I had maybe I didn't have another page with that. But anyhow, it is effective. Now, of course, it's somewhat invasive and not everybody is able to undergo an ECT procedure. If you have a pacemaker or something like that, it can't be used, but it is a possible treatment. And then repetitive transcranial magnetic stimulation. This is using a magnet to stimulate part of the brain, and this alters the cortical electrical activity and also seems to have an effect. But the most common treatments for depression are medications. And so we're going to talk about 3 different classes of medications. The first are these monoamine oxidase inhibitors, or MAOIs. MAOIs were the first antidepressant drugs that were developed, but now they're usually the last type prescribed. MAOIs block the enzyme monoamine oxidase, which breaks down serotonin and other catecholamines. And the idea with depression is that it seems that people who are diagnosed with depression have too little serotonin. They don't have enough serotonin. And so medications try to work by increasing the amount of serotonin in the person's body, brain. So if monoamine oxidase is an enzyme that breaks down serotonin, if you have a medication that inhibits monoamine oxidase, then it no longer breaks down serotonin, and the effect is to have more serotonin, which is the goal. So these MAOIs raise the level of serotonin at the synapse. There are other chemicals this works on as well, other monoamines, but serotonin is kind of the key that we're looking for. And they are effective. They're effective by leading to a decrease in depression, and that leads to our serotonin hypothesis of depression, the idea that there's not enough serotonin and that leads to these symptoms of depression. As I said, these were the first antidepressant drugs developed, but now they're usually the last type prescribed because people who take MAOIs must avoid many foods that contain tyramine. And tyramine is in lots of foods like aged cheese, wine, and chocolate, actually quite delicious foods, because when it's combined, that medication is combined with these foods, it leads to a dangerous level of increased blood pressure. So people have to leave out certain foods from their diet, and like I said, these are foods that often are very pleasurable, and so to leave those out is hard, and also, again, you end up with this dangerous potential side effect based on the person's diet. So this becomes less of a first choice medication. Now, the tricyclic antidepressants are another type of medication, an antidepressant, and they work by inhibiting the reuptake of monoamines, including serotonin. So they prevent the reuptake of serotonin and other neurotransmitters in the synapse. And again, if you remember, neurotransmitters are released and then they're brought back up into the synapse in this process of reuptake to clear the synapse of a neurotransmitter. But if we block reuptake, then again, you end up with serotonin being released, not retaken up again, and there's more serotonin in the synapse. An example of a tricyclic is imipramine. It's also called tofranil, but there are many tricyclics. This was a great improvement in terms of medications, but there are many side effects. People complain of dry mouth, drowsiness, difficulty urinating, and they can be possibly fatal in overdose. which led to kind of our newer antidepressants called SSRIs, or selective serotonin reuptake inhibitors. The key here is this word selective serotonin, meaning instead of blocking the reuptake of a lot of different neurotransmitters, this whole class of neurotransmitters called monoamines, of which serotonin is one. These SSRIs, this is like Prozac, selectively block the reuptake of serotonin. And so you end up again with increased serotonin in the synapse, which is the goal, and there are less side effects because you're not messing with the reuptake of lots of different chemicals and neurotransmitters. You're only selectively targeting serotonin. And so the less neurotransmitters you're affecting in the brain, the less side effects. And so selective serotonin reuptake inhibitors are usually our first choice for medications. And if they don't work, then maybe they would try tricyclics, and if those don't work, then to the MAOIs. And there is no rhyme or reason why some medications work for some people and some don't. This is one of the very frustrating and difficult parts of treating depression with medication, is that we don't know. We don't quite understand how exactly the mechanism works and why certain drugs are effective for some people and not for others. Let's see, the SSRIs, like I said, this is Prozac, Zoloft, Celexa, Paxil. They block the reuptake of serotonin, which is very similar to tricyclics, but they're specific to serotonin, and you get more mild side effects. There are also now some called these atypical antidepressants that have differential effects on reuptake of serotonin, dopamine, and norepinephrine. Wellbutrin was one of the first atypical antidepressants, and these also have mild side effects. And again, some are effective for some people and some aren't. The problem, so serotonin is implicated in depression, but the problem with the idea that it's reduced serotonin that causes depression is that there is often a lag time between the start of treatment and reduction of symptoms. So once someone starts taking the medication, let's say an SSRI, serotonin is increased pretty instantly in the synapse, yet people don't feel a reduction in their depression symptoms for weeks. It can be 2 or 3 weeks. And so that doesn't quite make sense. There must be more going on than we understand. And in fact, that's one of the, like I said, most difficult parts of treating depression, because if you have someone who is depressed and feeling hopeless and just having such a difficult time, you give them a medication and you say, please take this medication, you'll feel better in 3 or 4 weeks. That's a very long time for someone who is in a lot of pain mentally. And often as well, the side effects happen first. They happen pretty immediately. So the person could be feeling nauseous and dizzy and all of these very uncomfortable things, but they're not feeling the reduction in their depressive symptoms. And so it's sometimes people, very often people stop taking the medication before it becomes effective. And as I said, not everyone responds to SSRIs or any of these medications. So although they do work, so we do believe there's this association between serotonin and depression, if that was simply it, then that would work for everyone, but it doesn't. And so there are still some questions. So conclusions about antidepressants is exactly how antidepressant drugs work is unclear. The drug has a maximum effect in a few hours in terms of increasing serotonin, but the benefits may take days or weeks. Continued use, we see, may help restore hippocampus and cerebral cortex size, which is great. The brain starts to look even more normal. We think mood depends on the effects of a combination of neurotransmitters, even though we're focusing on serotonin, there are others involved. And different people have different neurotransmitter abnormalities, and there's research looking at this so that we can do a better idea or have a better idea of which person will respond best to which treatment. We also do therapy for depression. There are these negative thoughts that we see in people who are depressed. So they have negative thoughts, they see no point in trying, their mood is low, they feel guilty, discouraged, inadequate, and worthless, and then their behavior is reduced. They become less active, they avoid people and situations. When you do that, again, the thoughts become more negative. Look, I'm all alone, everything, I'm not around anybody, there's nothing fun happening, there's no point in trying. Then their mood gets more low, and again, their behavior gets reduced. And so you have this cycle that we try to break. One type of therapy that's been quite effective with depression is called cognitive behavioral therapy, or CBT, where we work on changing the person's thoughts, working on changing those very negative thoughts, and challenging their negative thoughts. What do you mean you're not? Nobody likes you. I'm sure let's talk about that. There's got to be somebody. Oh, yeah, you do have a friend. Okay. So it's not that nobody likes you. You do have a friend, and you do enjoy doing things with them, but you have stopped seeing them because you're in this depressed mode. And then we work on changing the behavior, cognitive behavior. So, all right, so let's try to call that person and try to do something, whether it's, go to a movie or even just talk on the phone or send an email. And then if we can kind of change this pattern, we see effects. And in fact, cognitive behavioral therapy can be as effective as medication. So we actually can see almost the same results. And people can choose if they want to take a pill. Some people like that idea, and some people don't like the idea of putting some kind of medication in their body that can have side effects, versus therapy, where therapy is takes maybe longer, right? You've got to go to therapy every week. You don't see the effects as immediately, but some people like that too. Or they can be used together, medication and therapy. When you do psychotherapy, you can actually see changes in the metabolic changes in the brain similar to drugs. And a decreased relapse rate. You're really teaching people how to kind of rethink in their life. And so when another cycle of depression happens, they're more able to kind of trigger those things they've learned in therapy and perhaps not go down into those depressive symptoms. But we do see about a 67% improvement with drugs or psychotherapy or both. So really, it's up to the person what they're comfortable with. And you see a 33% improvement with no treatment at all. And that's the idea that depression is cyclical. So after some amount of time, some people will just get better. They start to feel better and their mood improves even with no treatment. But you can see it's about double that if you do get treatment. You can read in your book about other treatments being researched. The vagal nerve stimulation with a mild electrical stimulation could be helpful. And deep brain stimulation, this is actually a surgical technique where you implant an electrode in the brain. And these are just some newer thoughts. In terms of depression, we said more women than men report suffering from major depression, and this may be because there are different patterns of help-seeking behavior. Women are more willing to seek help typically than men, and so because they're more likely to go to a therapist or a doctor, they're more likely to get the diagnosis. Also, gender differences in endocrine physiology related to the reproductive cycle and hormones, right? We see during and before a woman's menstrual cycle, you might see depression, and we also see postpartum depression, which is depression immediately following childbirth. All of these suggest a hormonal role in depression. We said postpartum Postpartum depression is depression after giving birth. It affects about 20% of women. Most of them recover quickly. 0.1% enter a serious long-lasting depression. And this postpartum depression is more common among women who have suffered depression at other times, experienced severe discomfort during the time around menstruation, and this might be associated with a drop in hormone levels at that time. Depression and sleep is also interesting. There's typically a disruption of sleep patterns. It's very common in depression. They typically are able to fall asleep but wake up early and then can't get back to sleep. We've got a reduction in stage 3, slow wave deep sleep. Patients enter REM sleep very quickly with an increase of REM in the first half of the night. And in fact, one of the treatments for depression can be sleep deprivation. A night of total sleep deprivation is the quickest known method of relieving depression. Again, when I worked in a psychiatric hospital with nurses around all night, we were able to do this, where you could keep a person up all night. Half who experienced relief became depressed again after the next night of sleep. But extended benefits can be derived from altering the sleep schedule on subsequent days, and using sleep alteration with drug therapies can provide long-lasting mechanisms, although the exact mechanism of how sleep disruption relieves depression is unknown at this point. And then signs of depression and observable behaviors. Learned helplessness is a common term in depression. The idea, and you can see this in animals as well as in humans, that if an animal is exposed to a repeatedly stressful situation that it can't escape from, you see this learned helplessness. And that's linked to a decrease in serotonin function, meaning the animal learns, like, I can't do anything about this. If there's an animal in a cage and every, I don't know, few minutes it gets a shock and there's nothing they can do to stop the shock, eventually they give up. In the beginning, they might try, oh, what if I walk into this corner? What if I try this corner? What if I press this bar? But when nothing works, eventually they give up. And that's kind of looks like depression, and you see those decrease in serotonin. Similar to humans, if they're in a very difficult situation that they can't get out of, a stressful situation they can't get out of, you see this learned helplessness. They give up, they feel hopeless, they feel like there's nothing they can do. Bipolar disorder, this is another mood disorder characterized by two different mood swings, basically, periods of depression alternating with periods of mania. And mania is a very, very happy mood. It's kind of the opposite of depression. Mania is like feeling so happy but for no reason, feeling high on drugs without being on drugs, just feeling totally euphoric but for no reason. And so people's behavior alternates between periods of mania and periods of depression. And like I said, that mania is episodes of increased energy. They don't need to sleep as much. They feel elation. They might be a little irritable. The bipolar phases of a bipolar disorder are usually shorter than the depressive phases. So bipolar may last only a day or weeks. Very rare for a year or more. Typically, it's shortened periods of mania and longer periods of depression. Bipolar 1 disorder, has people who are switching between depression and these full-blown episodes of mania. And bipolar 2 disorder is periods of depression and then periods of they wouldn't meet the criteria for mania, called hypomania. It's a little bit milder form of mania. About 1% of people have a mild case of bipolar disorder in their lifetime. We see a larger than normal amygdala, again, amygdala important for emotions in bipolar disorder. And this is one of the psychological disorders that have a pretty strong hereditary basis. We see a concordance rate in monozygotic twins. So monozygotic twins are identical twins. Identical twins share 100% of their genes, and the concordance rate means if one twin has the disorder, there's a 50% chance the other twin will have the disorder. And then if you're dizygotic, these are fraternal twins. Fraternal twins share 50% of their genes, as well as siblings who share 50% of their genes. Their concordance rate is 5 to 10%. So the more genes you have in common with someone who has bipolar disorder, the higher your risk of also developing bipolar disorder. So that's shows a strong kind of a genetic component. And bipolar has actually been linked to several genes, but we haven't found the specific gene yet. The brain changes in bipolar disorder are similar to what we see in schizophrenia, and we'll look at those in we'll look at those in the next lecture. We see enlarged ventricles. Ventricles are the holes in your brain that allow for cerebral spinal fluid to circulate through the brain. Those are normal. You have ventricles and they're important, but when they're enlarged, that means the holes are bigger. That's not a good thing. And what kind of goes along with that is if you have these enlarged ventricles or the bigger holes in your brain, then you have reduced actual brain, reduced gray matter, and that's not a good thing. The element lithium is an effective treatment to stabilize mood. We call medications for bipolar a mood stabilizer because if you could imagine kind of like almost like a teeter-totter or something at the park, right? You're switching between depression and mania. So what we're trying to do is stabilize the mood to get everything to be equal, kind of in a more typical range. That is what lithium is able to do. And has been reported to increase gray matter in patients' brains. That's a good thing, but its use must be monitored carefully for toxic side effects of overdose. In this toxic dose is just slightly higher than the treatment dose. And so that's kind of difficult because, again, you're giving this medication to someone who suffers from depression or is very impulsive in their episodes of mania. And so they have to be very careful in terms of taking the right amount of this medication. Anxiety disorders, this is a large group of disorders, and if you take an abnormal psychology class, you'll spend a lot of time talking about anxiety disorders. Anxiety disorders, there's a number of them. We have phobic disorders. This is when someone has an intense, irrational fear on a particular object or activity or situation, and the person avoids it. So this could be someone who has a phobia of dogs or a phobia of snakes or a phobia of heights. In some particular situation, they get an extreme anxiety response. Panic disorder, that's another disorder. This is when people have recurrent panic attacks. Panic attacks are periods of extreme fear. Their heart is racing. They can't catch their breath. People often feel like they're having a heart attack and often end up in the hospital when they have a panic attack. And so panic disorder is having recurrent panic attacks, intense fearful periods of intense fearfulness that's really very uncomfortable for the patient. And then generalized anxiety disorder is very much what it sounds like. This is someone who has anxiety over everything. It's persistent, excessive worry about everything all the time. They just can't calm down. They're worried about school and their family and their health and their financial situation, and it's just a constant state of worry. In terms of treating anxiety disorders, benzodiazepines are anxiolytic drugs that are used to treat anxiety. They bind to GABA receptors and enhance GABA's action. And remember, GABA is inhibitory. So GABA kind of slows everything down, slows your heart rate down, slows your brain waves down, slows everything down, which is what you need because in anxiety, everything is kind of, probably all of you have experienced anxiety at some point in your life. You just need to sort of calm down. And so that's what these drugs do. These GABA-A receptors are widely distributed in the brain, particularly in the cortex, hippocampus, and amygdala. And so GABA binds to these receptors and calms down your emotions, your thinking, and kind of lets people get back to this non-anxiety state. Serotonin agonists and SSRIs are also sometimes used to treat anxiety. Another anxiety disorder, post-traumatic stress disorder, or PTSD. This is where unpleasant memories repeatedly plague the individual. So after someone's had a traumatic experience, it can be combat related, it can be some kind of abuse, an accident, something, and then the person kind of re-experiences the trauma over and over. Um, and so the symptoms are memory changes. They may have some amnesia for the exact moment of the event. They might have flashbacks, again, where they re-experience it, deficits in short-term memory. What we see with people with PTSD, they have a smaller hippocampus, and it's hard to know because it may be that if you have a smaller hippocampus, that puts you at risk for being someone who, after the person exhibits a trauma, they're more at risk then to develop PTSD, or it could be a consequence of having PTSD, then the hippocampus gets smaller. It's really hard to know. But the people seem to be unable to really truly forget the experience, even if they're having some blockage of some of their memories. They're reliving it either in daytime flashbacks, nightmares, etc. Their body is also oversensitized, so any little noise makes them jump. Someone taps them on the shoulder, they jump. They have kind of this hypersensitive response. They also have lower levels of cortisol, which is interesting because cortisol is typically a stress hormone, but lower levels of cortisol, perhaps because they become increased in their sensitivity to it. So they become more sensitive to cortisol and eventually end up with less of it in their body. And so you end up with this fear conditioning response where the original trauma activates two systems, activates the brain stem, which sensitizes the person to related stimuli in the future, right? And these are these areas of the locus coeruleus, the ventral tegmental area, etc. And it activates the amygdala, which is the traumatic remembering. This is the emotional center of the brain that is also important in memory. And so you basically have kind of these interactions between these two areas, the brainstem and the amygdala, leading to this long-lasting fearful reaction. Obsessive-compulsive disorder, OCD, that's another anxiety disorder in which an individual experiences recurrent unwanted thoughts and engages in repetitive behaviors without reason or the ability to stop. So when we talk about obsessive-compulsive disorder, obsessive or obsessions are thoughts the person can't get out of their mind. Things like, oh my gosh, there's dirt everywhere, there's germs everywhere, something like that, a thought that they think over and over again. And a compulsion is a behavior that they can't stop doing. Maybe it's washing their hands. And so typically the obsessions and compulsions go together. So if someone has an obsessive thought about there being germs everywhere, then the compulsive behavior may be constantly washing their hands. So they have these unwanted thoughts, engages in the repetitive behaviors, and they can't stop. And this becomes a disorder. All of us may have some kind of obsessive thought now and then, but the inability to stop, you might have people who eventually can't leave their house because every time they wash their hands, they get to go to the door to leave the house, they touch their keys, they go, oh my gosh, the keys are dirty, they have germs on them, they have to go back, wash their hands, they get to the front door, maybe they use a glove, but then, I don't know, they take the glove off, they touch the car steering wheel, they have to wash their hands again. It's over and over, and eventually people maybe can't leave their house, they lose their jobs, things like that. So recurrent acts, those are compulsions. Recurrent thoughts, those are obsessions. OCD shows excellent response to cognitive behavioral therapy and also to SSRIs, suggesting that serotonin dysfunction plays a major role. And depression and OCD often occur together and may therefore be related. As well as being heritable, OCD may be triggered by infections that cause a damaging immune response. Very, very last resort might be psychosurgery for OCD, a cingulotomy, which are lesions that are made to interrupt the pathways in the cingulate cortex, or deep brain stimulation electrodes implanted in the basal ganglia and nucleus accumbens. But again, psychosurgery is pretty much a very, very last resort for a psychological disorder. Tourette syndrome, often comorbid with OCD, that involves abnormalities in the basal ganglia. Tourette syndrome patients have heightened sensitivity to tactile, auditory, and visual stimulus. It's usually diagnosed early, about 6 to 7 years old, and is often comorbid with ADHD, attention deficit hyperactivity disorder. In Tourette's, people have tics. They can be physical, like flinging their arms, kicking, shuddering. They can be verbal tics where they say a word and they can't stop from saying a particular word or phrase. In twin studies, the affected twin has more dopamine D2 receptors in the caudate nucleus of the basal ganglia than the unaffected twin. And treatments include haloperidol, which is a D2 receptor antagonist, meaning it blocks D2 receptors. Atypical antipsychotics, which we'll talk about when we talk about schizophrenia, behavior modification, as well as deep brain stimulation. All right, thank you very much, everybody.